I'm going to take the opportunity now to introduce our colleague, Suzanne Arnold. Dr. Arnold is an associate professor of medicine at St. Luke's, Mid-America Heart Institute, and the University of Missouri, Kansas City. Dr. Arnold's board certified in internal medicine, cardiology, and echocardiography. And she joined St. Luke's Health System in 2012. She's actively involved in multiple research projects, and particularly around studying outcomes of patients with valvular heart disease and patients with chronic coronary artery disease and heart disease and who have diabetes. She's been the recipient of several research awards, including the Burton Sobel Award for Excellence in Cardiovascular Research at Washington University in St. Louis, the American Heart Association Young Investigator Award, and a career development grant from the National Institutes of Health. Her clinical interests include valvular heart disease, geriatric cardiology, and quality of life. And we're very excited that Dr. Arnold has been able to join us this evening to really focus on quality of life in patients who undergo transcatheter aortic valve replacement. Susan, thanks very much for joining us this evening.
Well, thank you. I really appreciate the invitation to speak on the KCCQ and TAVR. I got into outcomes research about 15 years ago with a particular interest in the elderly and frailty and health status. And I had the fortune of being in Kansas City around the time when Partner 1 was finishing up, and we had the quality of life and economic sub-studies of Partner and Core Valve. And so I've had the opportunity to really be involved in this space from the beginning. And it's been really exciting because probably more than any other space, the transcatheter valve space really does seem to value health status and quality of life as an outcome. And so all of the pivotal clinical trials, it's a key outcome. It's obviously mandated in TVT because I think it's because it's important. And as a result, I think we really have a richer understanding of how these treatments impact patients. So over the last 10 years, we have really worked on how best to analyze these data, to present them, to understand them, particularly given the high mortality rates in patients who are eligible for transcatheter valve treatments. So hopefully over this time, I'll be able to provide some additional insight into what the KCCQ is, how to interpret it, what is a poor outcome, and perhaps how to use the KCCQ clinically. So I have no disclosures. So kind of just point number one, health status is a meaningful outcome. This is not a shocking statement to any clinician. We all know that patients care about how they feel, how they're able to function. But being able to measure this reliably and validly and having this be a key clinical endpoint in studies as well as clinical care, I think is a little bit newer. And why this is important is because health status can really fill the gap that mortality leaves. So mortality, while it's high in this population, still represents a small relative percentage of the patients. And kind of what health status helps answer is what happens to the other 98% of patients. Do they feel well? Do they feel poorly? And while there are other surrogate measures that can be used, such as rehospitalization, I think is probably the most common. I would argue that at the end of the day, what patients care about is, am I alive or dead? And how do I feel? And everything else, whether that's, MI, rehospitalization, revascularization, whatever those other endpoints are really surrogates, and they only matter in how they impact mortality and how they impact how patients feel and function. So just the term health status, just to help define that, we often use the term health status and quality of life interchangeably, and I do as well sometimes, but they are somewhat different concepts. So if we think about the disease process, in this case is heart failure or aortic stenosis, this disease causes symptoms, dyspnea and fatigue. These symptoms cause physical, emotional, and social limitations, which then impact a patient's quality of life, which we think about as being the discrepancy between a patient's actual and desired health and functioning. And the range of health status is that from symptoms, function, and quality of life. And this is really what the KCCQ overall summary score is designed to represent. So just this is a small study that I like to show that really demonstrates how much patients care about their quality of life. And I think the degree to which they value health status and quality of life as a reason to undergo treatment or a goal of treatment depends on a number of factors, including age, comorbidity burden, as well as symptom burden. This is a study of 51 patients with HFrEF, and they asked the patients to rank a number of hypothetical treatments that had different effects on outcomes. So this is one example hypothetical treatment. This treatment, the patient would not be tired or fatigued, but would still be short of breath and depressed, but would get a 3-month extension in their life. And what they found was that 65% of the patients placed more importance on symptoms than they did on survival. So again, just really highlighting that health status and quality of life is incredibly important to patients. And so understanding the effect of treatments on these outcomes and optimizing them is also an incredibly important treatment goal. So the KCCQ, which is kind of the thing that we're most talking about today, I want to describe a little bit about the history of the KCCQ and how to interpret it. So the KCCQ was developed in Kansas City by John Spertus, who I work with, and it was originally in 2000, so a bit before I got there. It has 23 questions in 5 domains: physical limitations, symptoms, social limitations, self-efficacy, and quality of life. And the 23 item is what's used in all the trials. It's what the FDA generally mandates. And the overall summary score is the average of the physical limitations, symptoms, social limitations, and quality of life. And this has been validated in a number of situations. It was originally developed in HFrEF patients, but we have subsequently validated it in HFpEF as well as aortic stenosis, and has been translated in a number of different languages. And what I do want to just briefly mention here, there are other summary scores. Probably the one that needs to be mentioned here is the clinical summary score, which is a average of physical limitations and symptoms. And while this isn't as much of an issue in the TAVR space, sometimes the clinical summary score is what the FDA will ask us to use as a primary health status measure. For example, in the recent Explorer study of HOCM, the clinical summary score was what was the primary health status measure. But generally, the overall summary score and clinical summary scores are highly correlated, and overall summary score is what we prefer to use. The shortened version, or 12-item KCCQ, was developed more recently, and this is what is collected in the TVT registry. And if the KCCQ were to be used clinically, this is what we would recommend to be used. There are 12 questions in 3 domains: physical limitations, symptoms, and quality of life, and the average of those 3 make up the overall summary score. Scores for all domains and summary scores range from 0 to 100, and higher scores indicate fewer symptoms, fewer physical functional limitations, and better quality of life. In terms of how to interpret the KCCQ, cross-sectionally, this is probably the best framework that we have. NYHA is not a particularly great measure for a number of reasons, and I'll talk about that here in a second. But we all have a clinical sense of what NYHA means. And so if we try to kind of say what a KCCQ is, over 75 is essentially minimally symptomatic or asymptomatic. 60 to 75 is NYHA class 2, 45 to 60 class 3, and less than 45 is class 4. And in a number of situations, cross-sectionally, lower scores indicate higher risk for both mortality as well as heart failure hospitalization. In terms of change scores, the KCQ is actually a bit unique here in that there was an explicit interpretability study. So they took patients in clinic and said, you know, are you a little bit better? Are you a lot better? They had the physician's rate. Are you a little bit better? Are you a lot better? And then looked at their KCCQs. And so these change scores are pretty well established. That 5 points is considered a small but clinically meaningful change. 10 is moderate and 20 is large. And again, not surprisingly, but a change in score is associated with a change in the risk of mortality and heart failure hospitalization. In terms of TAVR, these relationships have also held. So if you look at, these were data from the early experience of TAVR, showing that a low KCCQ score prior to TAVR is associated with increased risk of mortality after TAVR. And more recently, we looked at the KCCQ scores at baseline and at 30 days, as well as the change, to try to understand which of these measures is the most prognostically important over the next 11 months, and found that every 5-point increase in KCCQ was associated with a significant reduction in the risk of mortality and heart failure hospitalization. I do want to mention here that of all of those measures that we looked at, baseline, change, and 30 days, the 30-day measure was the most important. So it really is about kind of where you end up at 30 days, more so than where you start or how you change in terms of prognosis. So that's kind of what the KCCQ is, how to interpret it. I would like to just briefly talk about how this could be used clinically, kind of what is a framework. We collect these data for registry purposes, and it's incredibly helpful for me for research purposes, as well as a lot of other really interesting research questions. But I think we're really missing an opportunity when we're collecting these data if we're not using them clinically. Part of this is I think that we have to find mechanisms to have the scores available when the patients are actually in clinic, so that it is clinically actionable and not just a research tool. But to, I think, understand how to use this clinically, you have to know what to expect. What are the KCCQ scores that I should expect at baseline, and then what are changes that I would expect after TAVR? So these are just a range of risk from partner 1, early experience in TVT, and then partner 3. And you can see that the greater the comorbidity burden, the more advanced the disease, the lower the KCCQ scores at baseline. And I think that showing this is the first time I've seen your data from Michigan, but it looks like a lot of the patients that you're seeing in Michigan are kind of following this path of this orange and TVT. When we see patients that are lower risk who really have just isolated aortic stenosis without a lot of other heart failure or other comorbidities, we're still seeing a substantial burden in terms of health status, but not as much as the sicker patients. But even in those low risk patients, we're seeing moderate to large improvements at 30 days. So, 20 to 30 point improvement in KCCQ, which is a very large clinically meaningful change, is not unexpected. It's typically, we see a small improvement between 1 month and 6 months, and pretty much stable from 6 to 12 months. And this depends a little bit on how frail is the patient, do they take a little bit more time to recover? And then the biggest thing here is access sites. So alternative access requires a little bit more time to recover. However, the vast majority of health status improvement is within 30 days. But it's also important to recognize that those are mean changes, and there's a lot of variability around all of those measurements. These were data from partner 1, so both A and B, just the TAVR arms. And you have baseline KCCQ on the x-axis and 6 month on the y-axis. And you can see that even while most of the patients were highly symptomatic in terms of their AS, there's a wide range of both baseline KCCQs as well as 6 month scores. And in this data set, we found that 17% of the patients at 6 months still had KCCQ scores of less than 45. So this is essentially roughly equivalent to NYHA class 4. An additional 16% had scores between 45 and 60. And so understanding this variability and looking for these people who have suboptimal response to treatment, I think is where this can be most clinically useful. A few things I think that are important to remember when you're looking at KCCQ scores, as well as their relationships over time, is before TAVR, patients who have low KCCQ scores are more likely to die, but also more likely to have an increase in their KCCQ score. So they have more opportunity to improve if they survive. If you look at patients at 1 month post-TAVR, if there's suboptimal, not a big increase or a decline in health status, or the cross-sectional, the absolute score is low, these patients are more likely to die and more likely to be rehospitalized. So this is kind of a framework of how we have thought that the KCCQ could be used clinically in the transcatheter space. And so we sort of identified this group of KCCQ between 40 and 75 as being what we call the target population, meaning that they're likely to survive the procedure, they're likely to survive 1 year after, but also have an opportunity to improve in terms of their health status. Patients with a good quality of life coming in are very reasonable candidates. They definitely have a high likelihood of surviving the procedure, as well as the 1 year after, but could also be considered for surveillance because they are essentially minimally symptomatic. And then there's this group down here who have very low KCCQ scores, and they do have a significant opportunity to improve, but they're also have a higher risk of dying. And so I think looking at the comorbidities to see if they're reversible or irreversible, I think can be helpful here. But certainly, this is not something that we think should be used necessarily for futility assessment. At 30 days, this is kind of where we think this is most helpful. So this is looking at the health status response to treatment, and that if the score is less than 60, or the improvement is under 10, unless the patient started out with a very good quality of life, really looking at flagging those patients to say why. Was there a suboptimal procedural result? Is there PPL? Was there a complication? Is there concomitant cardiac comorbidities such as systolic dysfunction, coronary disease, mitral regurgitation that we can address? Are there non-cardiac comorbidities, COPD, that might be depression that might be optimized? And I think this is where perhaps rehab can play a role, particularly in the patients who are frail, who are having a harder time recovering their quality of life. This is a time to kind of flag these patients to say, okay, how can we make them better? And not just we get their KCCQ, we get their echo, and valve looks great. So I mentioned earlier that NYHA is not an ideal measure here. I think that we often say, I can interview patients, I can tell if they're better, if they're not. Why do I need to do a patient-reported measure? Is NYHA or is exercise testing perhaps a better substitute? And I think no matter what place we look at this, if you look at patient-reported symptoms and physician-estimated symptoms, they often do not correlate well. So these are data from pre-TAVR in TVT, 170,000 patients. And of the patients down here who rated a very poor health status, so essentially rated themselves as NYHA class 4, you can see the variability in how the physicians estimate their symptoms. So 16% were rated as class 2. And then on the other side, patients who reported minimal symptoms or even maybe asymptomatic, 46% were rated class 3 and 43% class 2. And if you look at this across different sites, it's not a systematic bias. It's not, we actually went into this study thinking, oh, physicians are going to overestimate a patient's symptoms at baseline and underestimate them at 1 month. And we actually didn't find that. We just found that there was a lot of discrepancy between the two. And when you look at just beyond the fact that there is discrepancy, the KCCQ is more prognostically important than the NYHA, and this is just 30-day mortality. So this isn't even getting to longer-term mortality. Just briefly want to touch on exercise capacity, because I think that this is getting a little bit more push that it is an objective measure as opposed to, say, the KCCQ, which has some subjectivity to it. These are data study we did in COAPT, so this is mitral space, but I think really does translate without any issue. And then just importantly is that health status and exercise capacity are actually looking at two related but distinct things. And so what we found was that the health status was more associated with risk of heart failure hospitalization, whereas exercise capacity was a stronger predictor of mortality. And this made a lot of sense in that exercise capacity has always been associated with mortality, whereas the KCCQ, of being disease specific, is going to be more associated with the things along that pathway. And so as a result, if you look at change from baseline to 1 month, both are important, but the effect size for KCCQ was much higher than for exercise testing. What that means is that it was much more sensitive to change. So while exercise capacity is prognostically important, I think it can really help identify perhaps patients who are not going to do well after the procedure, really no matter what you do. The KCCQ is going to be much better at monitoring for treatment success or the effect of the treatment on patients. So I think that this is where I think we have spent a lot of time and effort over the last decade is how do we assess long-term health status in TAVR, and how do you interpret those numbers? And a lot of this has to do with this issue of mortality and the fact that mortality and health status are not independent of each other. I showed earlier how important the KCCQ is in predicting patients who are not going to do well. So what this does is this makes it difficult sometimes to interpret the KCCQ scores at 1 year. The reason is that health status can only be assessed in surviving patients. That's easy to understand. You can only ask this in people who can answer back. Patients with worse health status are more likely to die. And the issue is if you systematically remove the sickest patients from your cohort, it ends up biasing the results. And so it makes the health status of your surviving patients look better than it otherwise would had those patients survived. And from a research perspective, this isn't an issue when you have differential mortality between two groups. So for example, in COAPT, where there was a difference in mortality, we had to do some kind of special analysis to account for that differential mortality to really understand the effect of the treatment on health status. This was a similar study. This was actually where this is John Spertus's son who actually did this analysis in partner 1B. So again, big difference in mortality between the two groups. On the left, you see what was the original health status. Green is the TAVR arm, red is the medical therapy arm. There's obviously a big difference between the two, but the mortality was much higher in the medical therapy arm. And so when you account for that differential mortality, the difference between the two groups becomes much larger. And this is where we came up with this idea that we had to somewhat account for this mortality, that you can't just report mortality and report health status and try to interpret those independently, but understanding how the treatments impact kind of both, which is again, holistically what patients care about. Are they alive or dead, and how do they feel? And this is where the kind of poor outcome definition really came from. So this was just an example of how we had previously reported outcomes. We talked about being alive and better thinking that that was the best way to describe the health status outcomes in these groups. But one of the things that we found was that that didn't really represent, alive and better doesn't necessarily represent a good outcome for all of the patients. And I'll try to describe what I mean by that. So this was the graph that I showed earlier with baseline KCCQ on the x-axis and 6-month on the y-axis. And we originally kind of came to this analysis as a futility analysis. So we were trying to predict the cohort C patients, who are the patients that are not going to do well no matter what you do. And we initially had this idea that that outcome would be alive and better. Like, well, what should you expect? You should expect to be alive and you should expect to improve your health status. And one of the issues with that is that, so this is alive and better, so an increase in 10 points, is that there's this group of patients up here who actually start with a pretty reasonable quality of life. And at the end of 6 months, they're alive, but they're not better, but they're not worse, and they're still feeling well. Well, that doesn't seem like that should be a poor outcome. TAVR has a survival advantage, and so being alive and with a good quality of life seemed very reasonable to us. So then we said, okay, well, let's just use a threshold. Let's say 45. You should have, at the end of 6 months, you should be alive and at least have a KCCQ above 45. So not be short of breath at rest, not be NYHA class 4. And then we said, well, there's this group of patients over here who started out with a good quality of life and actually got worse. And we thought, well, that doesn't seem like that should be a good outcome after TAVR. And so that's when we came up with this. So this is essentially what the poor outcome is. So it says that I have to get to at least a threshold of 45. And if I'm above that, I need to just be not worse. Now, we mentioned that there is this other thing that we called a favorable outcome. And the reason for that is we said, well, this acceptable outcome is sort of the minimum acceptable outcome. So it's not really what you would expect. It's not a good outcome. But if you're trying to look at the issue of futility or that type of thing, this is sort of the minimum, live 6 months and not NYHA class 4. If you start talking about more acceptable sort of, or favorable sort of what you actually would say, yeah, you know what, that's actually a reasonable outcome. But then we kind of extend things. So you say, you don't have to just survive 6 months, but you need to survive a year. And if you survive a year, you need to have a KCCQ of at least 60 and then also be not worse. And so that's why there are the two different thresholds for KCCQ, is that one is supposed to be essentially equivalent to survival for 6 months, and the other is survival for a year. And part of this is that you're dealing with a combined endpoint. And so a person meets that endpoint if they meet either of those two. And so anytime you do a combined endpoint, you want the parts of that combined endpoint to be roughly equivalent. And that was kind of our concept. The other issue with this is that when we looked at can we predict patients who are going to have a poor outcome or not or a favorable outcome, one of the issues that we kind of ran into is that a low KCCQ, those patients are more likely to die, but a low KCCQ was also more likely to improve. And so if you use this combined endpoint of alive and improved, the association of KCCQ with the two parts of that outcome go in different directions, which you shouldn't have a predictor of an outcome that goes in different directions. It doesn't really make sense. So going through kind of what, again, what to expect, and I think this is where things have changed over time and as the risk of the patients has changed. So these are poor outcomes at a year. So this is, again, the 60-point threshold. And if you look at the original extreme and high risk groups, it was about half of the patients were either dead or had persistently poor quality of life health status at a year. As you started moving into more intermediate risk, you start going down, whereas S3 was about a quarter. And then in the partner 3, low risk, this is about 6%. It's pretty rare to see these numbers clinically. I think in the 25 to 30% is pretty reasonable. And you can see the breakdown between those two outcomes. So this is, the death still represents a substantial proportion of patients that have a poor outcome at a year, as opposed to just the health status portion of the definition. So I mentioned earlier that we were trying to identify the cohort C patients and really to understand who are the patients who are at high risk for these poor outcomes. And our original plan was to say, could we identify these patients ahead of time such that, we could kind of shunt these patients more towards palliative care. And I think that didn't really work very well. And I think a lot of it had to do with we weren't able to identify a group of patients with such a high risk of a poor outcome that you could easily say, no, we shouldn't do TAVR. But I think that this work really did help us to understand who are the patients who are high risk, but also to flag some of those patients for perhaps more intensive rehab, or some have argued, what do they call it, prehab. I don't think that that's probably appropriate necessarily in the TAVR population, because I think you sort of need to treat the AS, but at least knowing kind of what you're getting into. So this was the outcomes model that we developed in Partner 1. We validated it in CoreVal and subsequently validated in TVT. And this is the grouping. So we have those are low, intermediate, high, and very high risk. And so if we look at this very high risk group of patients, 58% were dead, an additional 18% had persistently poor quality of life at a year. I mean, that's a huge percentage, but if you look at the counter of that, a quarter or 20% of the patients actually did okay, despite being very high risk. And so again, I think that using this for more, patient selection maybe, but more patient counseling and also aggressive treatment post. So the factors that really went into this model, we have kind of what we call the moderate risk factors. So AFib, moderately reduced KCCQ, limited functional capacity, stage 3 chronic kidney disease, and then low mean aortic gradient. And then the strongest ones, the ones to really pay attention to, are more advanced chronic kidney disease, home oxygen, very low KCCQ, wheelchair-bound, moderate to severe dementia. Mild dementia doesn't seem to have much of a role here. ADL dependency, and then that's probably the strongest here. And then cachexia, or unintentional weight loss. And kind of the way that I've tried to think about it is that if you have any two of these strong risk factors, at least need to have a very strong conversation with the patient about what their goals of care are, and that they can understand that they are at very high risk for a poor outcome, so that the expectations are appropriate. Okay, so last thing I just wanted to very briefly touch on is the other thing that KCCQ plays a role in TVT, and this is with the 30-day composite. And I hope that you guys are getting this, and I think this is actually being in the quality reports. But the 30-day composite basically looks at the outcomes of the patients at 30 days and tries to say, well, based on those outcomes at 30 days, what are their long-term outcomes, and am I doing well or not? And I think it's a way to judge quality of care just based on the 30 days as best that we can. And so this was developed in 50,000 patients who underwent TAVR. And we did this kind of what we call a hierarchical 30-day outcome. And the statistics of this are a little bit complicated. But basically, this is the hierarchy of importance of outcomes. So death, then stroke, then AKI stage 3, major bleeding, moderate to severe PVO, and then none. And what the statistics of this is, you basically take each patient at the treating hospital, and you pair them with a hypothetical patient who has identical risk factors and are treated at an average performing hospital, and you do essentially win ratios. And with that, you can calculate the site difference for each individual site. And this hierarchy came from the study that we had done just a year earlier, where we looked at the effect of complications at 30 days on long-term outcomes. And so we were looking at the effect of these complications at 30 days on one-year mortality as well as KCCQ. And the ones that were most important were higher up on the hierarchy. And so we don't need to get into the details of these numbers. I just wanted to kind of highlight where that composite comes from, and it comes from the relationship of those complications with one-year mortality as well as KCCQ. I think that's my last slide. Oh, I have a summary slide. Okay, so in summary, health status is a meaningful outcome. Patients care a lot about it. It helps inform prognosis, but also is an important outcome in itself. So continuing to, one, collect it, I think is important, because if you don't know where you are, you don't know how to improve. But just using strategies to optimize patients' health status over time, I think can be really meaningful to patients. It can be useful for both patient selection, but also more for risk assessment. I think really could play a role in the assessment of responsive treatment. And so identifying those patients at 30 days who may benefit from additional treatments, whatever those might be. And then in terms of the poor outcome, I think that this is a way that we can integrate survival with the KCCQ to provide a more holistic, complete picture of patient outcomes. Okay, and now I think that's it. Yes, and I'm happy to answer any questions.
Suzanne, that was wonderful. Thank you so much. While people are thinking of questions, I guess I had a couple. I mean, you have a lot of experience, obviously, working with this data and working with TVT. We're trying to improve the collection of this data, not only a baseline, but 30 days and 1 year. Do you have any advice or suggestions for our teams across the state and in what's been successful either in Kansas City or that you've seen across the country and in collecting this data efficiently and making sure that it gets not only into the clinician's hands, but gets into the registry?
Yeah, so I think that, I mean, you are absolutely not the only ones who are challenged by this. You know, if you look at completion at a year, missing data is a huge issue. So, you know, I think that the one thing with the KCCQ, the one thing with this is that it can be done remotely. So you don't actually have to touch the patients in person to do the KCCQ. This can be done over the phone. So as a, you know, I know that at least here, you know, Kansas and Missouri are fairly spread out. We have a lot of rural populations. And so it's a bit of a struggle to get patients to get back into clinic, even for their 1 year follow-up appointment. And so it is something that if you prioritize it as a this is something that we want to do, getting that remotely, I think is absolutely reasonable. And that's how the KCCQ can be done pretty easily.
Yeah, I think that, that's something we try to emphasize with our sites around the state, is that you can collect this remotely. Obviously, that's been even more relevant in the last couple of years. So that's wonderful. I know this has been well validated, but there's obviously been a lot of focus on underrepresented populations and trying to make sure that we're addressing issues in minorities and economically disadvantaged populations. Are there any issues with the KCCQ or differences in the KCCQ that you've seen in these populations relative to the general population?
Yeah, I don't know of any specific in terms of economics or race. Obviously, the aortic stenosis population is heavily Caucasian, which makes it difficult to look at in there. We have looked at it specifically in men and women, and there aren't issues there. I think the only thing with any of the health status measures is if you look at it with age, it can be a little bit different in that older patients, really old patients, tend to moderate their activity a little bit more. And so they may say they're doing better than a younger patient would with the same level of disease, because the younger patient is pushing themselves more. And so that's, I think, the only thing from a demographic perspective that we see, and we see that with the Seattle Angina Questionnaire, the peripheral artery questionnaire, all of those health status measures that have issues with function and symptoms, that older patients tend to moderate their activity more than younger patients.
Right. One of our colleagues, Devraj Sukal, had a question. First of all, thank you again for a fantastic talk. But he asks, is there a difference in KCCQ scores depending on whether the patient is completing the form with or without help, i.e. a family member helping them or a healthcare provider? Is the validity affected, and you maybe already mentioned this, if it's done remotely or with or without help?
Right. So I think that whether or not the questions are read to the patient, or the patient reads it and does it themselves, I don't think that there's any issues with that. I think anytime somebody tries to interpret a question for a patient, well, this is what this means, that can be a little bit more challenging, but I don't know of any specific way that that's been studied. I know that the only thing I can think about is, in like INTERMACS, for example, where you're looking at the LVAD population, there are a number of places where, the surrogates are filling the KCCQ patient for the patient who can't speak. And that's the best data we have. And, I don't know that it makes it really challenging to know if it's valid or not, because it's not like you can have the comparison. So I think I think if the questions are being read to the patient, I don't think there's an issue. I think it's just if you have interpretation pieces, that can be a bit more challenging. But
I guess one other question for me, and maybe I don't know if anybody else has questions, but we've had a lot of interest for many years in using these health status questionnaires clinically, and how have you seen sort of growth and use of these clinically, not only maybe in the aortic stenosis population, but in the heart failure or other cardiovascular disease population over the last several years?
Yeah, so this has been, I think, one of the biggest frustrations, because I think we know how powerful these data can be. And the other thing I think has really been one of the things that I really like about the KCCQ is not just in the AS population, but probably more for the heart failure population, is being able to monitor patients over time, as well as cross providers, because we know NYHA is going to be different depending on who fills it out, whereas the KCCQ is going to be consistent. I think that that's a piece that's been really helpful. We've integrated into our advanced heart failure clinic, and it's been a little challenging, but we have a lot of Epic places around here, but Epic has a template in there, which has kind of allowed it to be integrated so that people can, the scores have to be entered in, in terms of the questions, but it spits out the score. And so that's helpful. If there is an app that one of my colleagues designed is designed to help people, so patients can fill it out ahead of time and kind of send it, and it can link to Epic. To be honest, I don't know exactly how to direct you to that. but that's something that we have done in our clinic population. And then if there's ever a time where it's something that it's scoring and getting it used clinically, John Spertus is incredibly collaborative. He owns the copyright to the KCCQ and is incredibly passionate about it being used clinically. So I think anybody can, and reaching out to him and to Health Outcomes HOS, they can really, I think, be helpful in terms of coming up with ways to use it clinically, because I think we're missing a huge opportunity.
Great. Well, Suzanne, thank you so much. It's been a wonderful education for all of us, and really want to thank you for your leadership in this and for sharing a few minutes with us. I'm sure we'll be talking to you again. So thank you very much.
Great. Thank you. Appreciate it.
Wonderful.